Madhivanan, Manoj Khatri to come over and occupy the seats on the dais. Where is Nivian? We have an excellent faculty, got some interesting topics as well, and we are looking forward to a good interaction. And each of these talks will be for about 10 minutes, and we'll have some time for discussion, hopefully. Pratap, please clear. Or you stay back. Stay back from my course. Friends, good morning. I'm Dr. Mohan Rajan, and we are going to talk about these three techniques or these three conditions, that is the dangling lenses, the decentered lenses, and the dislocated IOLs, and how to fix and what to do. And we have got an excellent faculty, and I'm going to talk on after PCR, what next, suture scleral fixation and management of subluxated IOLs by Dr. Sujata. Dr. Amar Agarwal doesn't require any introduction, glued IOL tips and tricks. Nivian is going to talk about iris claw lens and new invention, CMT flex lens. Manoj Khatri, dropped IOLs. So we'll also be talking on the precision versatility of flax in complex cases at the end of it. And how many of you in this audience have not had PCR at all? Nivian is there, okay, because he doesn't do cataract surgery. If you don't do cataract surgery, you will not get PCR, or you're telling lies. Okay, let me see what we can do for PCR, what we'll do. Anticipate PCR in traumatic cataracts, cataract post-vitrectomy, posterior polar cataracts, hard-brown cataracts, pseudo-exfoliation. As you know, PCR can occur at any stage, and can you just time it for 10 minutes, please? Complications can occur if you don't manage the PCR, like endophthalmitis, secondary glaucoma, uveitis, and all these problems can occur. So if you have PCR, the most important thing is, you can notice that if you have PCR, please don't panic. That's very important. And do not pull out. If you pull out, what will happen is, whatever is a small PCR will become a huge PCR, and vitreous is like a tsunami, and more vitreous. What happened, man? What happened? Okay, any stage can occur, and you can see that during hydrodissection nucleus removal. The most common time is during the, the cortex removal, because of the posterior capsule. And all these problems can occur, like cystoid macular edema, retinal detachment. As I told you, do not pull out, very important. And if you understand this graphic is very important. When you have PCR, do not have coaxial irrigation aspiration. Coaxial by mean base, when you have the irrigation aspiration in the same port. So when you have a PCR, switch over to separate irrigation aspiration. Separate the irrigation aspiration, separate the irrigation for the cutter. And if you have PCR, do not panic and inject viscoelastic, preferably viscoat, because the viscoat will go and plug. As you can see here, this is a patient who had a PCR. You can see a small, PC tear there. I didn't panic, I just removed the nucleus, a hard brown cataract, and injected viscoat through the side port. And once you inject viscoat to the side port, you can see that it stabilizes the anterior chamber. And immediately switch over to the, you can see that I'm injecting a viscoat that plugs the PC tear, and then immediately create a right side port and go bimanual. Don't use unimanual or a coaxial, because that is going to hydrate the vitreous and make the PC tear more. And you can see here, this hydro rupture, every time you do a hydro dissection, okay, this is again very, very important. You need to decompress the nucleus and you back into the back. Otherwise, you can have a hydro. Can you see that the capsule is opening up there? 100% this capsule, this rhexis will extend across the equator and then go into the posterior capsule. By the time you put the phaco probe, the entire nucleus will go into the thing. You can see this is a posterior polar cataract. I tried to remove the epinucleus, and I had a PC tear. There's a sudden deepening of the posterior chamber. immediately injected viscoat, whatever viscoelastic you have, immediately put tricot. First, always remove the vitreous first, and you use the tricot, because the tricot delineates the vitreous. Even God cannot see the vitreous without the tricot. So dilute the tricot 1:3 and make sure that you don't put too much of tricot, because you'll lose the red glow as well. And you can see that I use a bimanual technique, remove the vitreous first and then remove the, don't be in a hurry to remove the cortex and the epinucleus again. Again, another patient, you can see the PC IOL, the PC tear occurring. There is a tear which is going linear. You can see that linear across on the PC. And you can see that this is very difficult to convert this tear into a posterior capsular excess. But what is important is when you have a small PC tear, convert that into a posterior capsular excess. Again, this happened, you can see here. This is a patient wherein, I'm sorry, the video has not come. Whatever it is, this is a postoperative patient. Again, another patient with the PPC. You can see here the PPC, there is a huge, it's not actually a tear, it's a pre-existing dehiscence which is there in the posterior capsule. Very typically, you can see in PPC, there are two pillars in the posterior capsule. And when you do remove the epinucleus, sometimes you can see in the, I do the flax for most of these patients, but this was prior to the flax when you got it. But what is important is stabilize the chamber every time you come out of the eye, whether you have Hyalon or HPMC. HPMC normally we don't use because you don't want the HPMC to mix with the vitreous. Again, very important. See how I'm stabilizing that and injecting Viscoat or Hyalon or sodium hyaluronate, which is all Indian companies are also making this without much cost as well. So remove the vitreous. You can see the typical two pillars on the posterior capsule, which is very typical of this thing. When you put a multi-piece lens, make sure that put the multi-piece lens, put the haptic in the bag, and don't leave it haptic in the sulcus. But don't leave it in the sulcus. If you leave it in the sulcus, there can be a long-term decentration and even optic, UGH syndrome. So always capture the optic into the capsular excess margin. Can you see that how the capturing occurs? This is an optic capture. The lens gets clogged and the lens will not move a micron. So this is the end point is the ovalization of the capsular excess margin. Again, very important for you to understand this ball game. So this again, when you have a mature cataract, look at the fellow eye. If you look, fellow eye has got an AC IOL or a glued IOL or an iris claw lens. There's a possibility of a posterior polar cataract in this, okay? Because this same thing would have happened in the other eye as well. So this patient had an AC IOL in the other eye, done elsewhere, and this is a posterior polar cataract. Again, you can see here I do a femto, unless otherwise the patient cannot afford. But even then, femto is a mature cataract. I did a femto catalyst, and you can see how beautifully the nucleus is. There's so much of intraoperative control is much better. But what is important is once you remove the nucleus, you can see it's a fairly soft nucleus, young patient. You can see that typical. You can see the pigments and the cortex in the anterior capsule. This is not actually a PC tear. It's a PC dehiscence which occurs in this thing. Again, going ahead, injecting viscoelastic, create a bimanual technique, inject viscoelastic, come out. And fortunately for me, till now, there is no vitreous. But I tried to be a little more overzealous. That's what you should not do in a posterior polar cataract. So I tried to remove that cortex. You can see that. I tried to remove that cortex on that side. And you can see that I ruptured the PC. And ruptured the anterior hyalod, not the PC. Already PC is ruptured. I ruptured the anterior hyalod. And obviously, I have to go ahead and do a vitrectomy and put a lens, 3-piece lens in the sulcus and capture it in the back. So again, these are all the patients optic capture, where you can see 2 months, 6 months, and 3 years. And all these patients do very well. And again, another patient with a posterior polar cataract, you can see here how it is going on very well without any problem at all with the femto. Again, a patient, you can see here how a posterior polar cataract, again, very important for you to understand this ball game, very important. You can see that the two typical lines on the posterior capsule, very difficult to do a posterior capsular excess because these lines are extending from one pole to the one side of the equator to another across the posterior capsule. It's a PC dehiscence, making sure, in this case, I was not able to, I made sure that the anterior hyalod is very intact, and you can see that anterior hyalod is intact, and went ahead and put a multi-piece lens into the bag and captured that into the sulcus, into the sulcus and captured the optic into the bag as well. Again, another patient with PCR, again, you can go either limbal or pars plana. What I do normally is to do a pars plana. Only thing is that anti-segment surgeons, you have a little difficulty in going through the pars plana because you need to put a trocar and cannula, make sure that the eye is firm, put a suture there because it always makes important. Again, femto PCR, we'll show it later when we have time. Again, another patient, the nucleus drop, and we can do an anterior-assisted levitation, or you can do go ahead and put a ACIOL in this case because the patient was very old, and put an ACIOL, the patient did very well. You can do a posterior-assisted levitation also, just to show you different types of things. The most important message is to prevention of PCR, anticipate PCR, do a bimanual technique, make sure that you remove the vitreous first, and these are all the IOL options which we are going to discuss. Either ACIOL, retro-iris fixated lenses, sutured scleral fixation, glued IOL, Yamane technique, and sulcus IOL. All these can be done. The moral of the story is very, very important, is that prevention of PCR, early recognition of PCR, good vitrectomy, bimanual techniques. These are all the important messages I want to give. Preferred practice protocols in PCR. Small PCR convert into PCC. Do not pull out, inject viscode. Use tricot preservative-free, bimanual automated anti-vitrectomy. Don't use your scissors or Vanna scissors or sponges. Remove the vitreous first and then remove the cortex and the epinucleus. Appropriate IOL, suture the wounds, very, very important because when you have a PCR, I always suture the wounds like micro leaks. The incidence of endophthalmitis goes up by about 4 to 5 times. Again, management of PCR is very, very important. Thank you again for all your wonderful patience and attention. And this is, again, another message I want to give. We'll go on to the next topic by Sujata, and she's going to talk to us on we'll take the questions at the end of it. Yeah.
Good morning, everybody. At the outset, I'd like to thank the organizers for giving us this opportunity. My topic is on dislocated IOL fixation techniques. So I'm going to show you different methods of fixing dislocated IOLs. So you can do it either ab interno, or you can do it as a scleral fixated IOL. The case one is a 70-year-old male with history of phaco-foldable done 15 years back at our hospital. Vision was 6/6, but his only complaint was that he had some oscillopsia. That means a shaky vision. And on examination, he had a pseudo-exfoliation present. And also you can see that the IOL is moving in the bag. You can see that's a multi-piece IOL which we used to use, MA60, we used to use long time back. And this case was done about 7-8 years back. So we decided to fixate the same IOL and glue it into position. So we are preparing the eye to receive the glued IOL. I'm using a pars plana infusion. Two flaps are being done 180 degrees apart. Chariot's pockets are being created. And now it's for us to lift the IOL. You can see how easily it is coming out. The whole thing can be lifted out so easily because almost all the zonules have gone off, and maybe in another 6 months' time it would have fallen onto the vitreous. So now I'm resting it on top of the iris and trying to remove the capsule around the lens. But it's not possible, so I'm using a vitrector to remove the posterior capsule. There is no vitreous. I'm just using the vitrector only to remove the capsule. And once I've released the lens from the capsular bag, now I can fixate it into the sclera. So now you can see that using the handshake technique, I'm retrieving the one haptic. At the same time, holding on to the other haptic, and now the other haptic is also being retrieved. And once you've got both the haptics out, then they can be tucked into the scleral pockets which have been created. Some amount of capsular remnants are there which can be handled with vitrectomy. And in this particular case, we didn't disturb the vitreous at all. So once this is done, we glue the flaps together and the case is completed. This patient had an excellent outcome. The same thing is coming. So this patient had an excellent outcome, as you can see that, when this is the first post-op day, when the eye moves, the lens is very stable. So the next case I'm going to show you is again a very similar situation, 70-year-old male, but this lens was a single-piece lens, and this was a dislocated IOL back complex, and patient also had pseudo-exfoliation. As you can see, this is a bag. You can see that the lens is moving. So
Sujata, 1 minute. Huh? There are some chairs in the front. Can you come over and sit here? Thank you very much.
So this time I decided to go for a Hoffman's pocket and to suture it into the sclera. So just a little bit of diagrammatical presentation to make you understand what are Hoffman's pockets. They are actually clear corneal incisions which are made about 300 microns deep, 300 to even 400 microns, and then you make a pocket into the sclera without disturbing the conjunctiva. So then once it is done, through the roof of the pocket, you can introduce a needle, 27-gauge needle, which is threaded onto the polypropylene, which can be passed through a side port incision. And you can loop it through the haptic. So this is what I'm going to show you now. So once it is looped, then you can bring out the suture from the pocket and tie it. So this is the surgery which I'm going to demonstrate, where you can see that I'm creating the Hoffman's pockets. The Hoffman's pockets, once you've done, you just have to make sure that it is at what width that you have it, so that when you introduce a needle through it, you don't go outside the pocket. So that you have to check it out nicely, and then you make also a side port, and now you're introducing the 27-gauge needle and passing the 10-0 polypropylene underneath the haptic and railroading it into the 27-gauge needle, which is again passed through the roof of the, and now it is coming on top of the haptic. So now you have a loop of suture around the haptic, and you pull it out now. And then you can retrieve the same loop from under the Hoffman's pockets, and you keep it aside. You do the same thing for the other side as well. Now you have Hoffman's pockets on both sides. Now you've got the loop of suture which you have kept. Don't suture it now. And see, again, a 26-gauge needle is introduced. You can see that it's going underneath the haptic, and a 10-0 polypropylene is railroaded into it. So you have one loop coming out. Now again, the second loop is going passing through the paracentesis, and now it's going on top. So you now have a loop which is pulling the haptics. So now once you have centered the haptic, you can pull out the sutures from under the pocket and tie it. Don't tie it too tight on one side, then it can shift totally. So just make sure that it's well centered and then tie it. And once that is done, the procedure is over. You don't have to use glue at all in this case. So this patient is again a patient who had a dislocated IOL. This was a third surgery we're doing on him, because every time he came to someone had done an IOL fixation, again it dislocated. So this time we decided the best method would be for him was to do a glued IOL. And again, it's a very similar situation where we have a multi-piece IOL, which is very fortunate, and we could retrieve the haptic from under the flap which has been created. And once it's very important to sever all the capsular remnants, because that could be one of the reasons why it keeps getting pulled down. And now you have retrieved the trailing haptic. You can also see that the rest of the haptic is also being retrieved, and both of them have come out, and they can be tucked into the chariot's pockets. And now the lens is well centered. We have, and after that he is not dislocated. So it's very important. One of the most stablest techniques of IOL fixation, I would say, is glued IOL. And Amar is an expert, so he's going to follow me and he's going to show you some fantastic surgeries. But we also have an experience of about from 2007, almost about 17 years, done several cases with excellent results. The last case I'm going to show you is dislocated single-piece IOL, where I'm going to use a Gothic suture. It's a very simple technique, and it can be done by anybody. So that's the reason why I wanted to show you this. I mean, it's not, I'm creating a flap. You need not create a flap, but I created a flap because I was not very sure I will be able to do it. I may need to exchange the lens. So I created a flap just in case I exchange the lens and do a glued IOL. So this is going to be very similar to the second case where I showed you where we're going to put a loop of suture around the IOL haptic. So in this case, what I'm doing is I'm putting an AC maintainer. Now I'm introducing a Gore-Tex suture. So these sutures are very strong and they don't disintegrate like the polypropylene sutures. And the first suture is passed under the haptic, and the second suture is now introduced and passed above the haptic. So you get a nice loop around the haptic. The same thing can be done on the other side. Through the paracentesis, you introduce the Gore-Tex suture, which is now passed on top of the haptic. So you make sure there is no twisting of the lens. And then the rest of it is from underneath. So basically on one side you go on top, the other side you go from the bottom. So you get a loop so that without the lens getting twisted. And then again you center the lens, and you can see a lot of capsule remnants is there. So that has to be removed. Vitrectomy has to be done. So I've just loosely tied the lens. And what I'm going to do is I'm going to do a vitrectomy to remove all the capsule remnants, and I'm also checking to see if there's any vitreous disturbance. Fortunately, we didn't have any vitreous disturbance in this patient also. You can see there's a large L-shaped spurts that also has to be removed. These are a little bit difficult to remove. It has to be, anti-vitrectomy has to be used, and all the capsular remnants have been removed, and the suture is tightened. Ideally, it will be better to rotate the suture. In this case, I have not done it. I have a 5-year follow-up, and fortunately for me, nothing has happened, but Gore-Tex sutures are notorious for extruding, so they have to be rotated, and then I've glued it into position. So these are the different methods by which you can manage dislocated IOLs. If you have a single piece lens, then you can use one of these methods, or you can explant them and you can do a glued IOL, or if you have a multi-piece lens, you can glue the same IOL. It all depends upon the surgeon expertise, the type of IOL, and the complexity of the case. But I would strongly recommend, all of you do try it, because it is not as difficult as it looks.
Fantastic. Very nice, Sujata. Fantastic videos. You have shown the different ways to skin the cat, and over to the master, Dr. Amar Agarwal, who has invented so many things. And one of them is a glued IOL, and we're going to talk about it. And we are doing this course successfully, not only in AOS, but also in ASCRS, ASCRS, AO. And I'm very fortunate to have Amar as a faculty in this course as well. Thank you, Amar.
So by the time sir starts, just one quick question. Any reason why you are putting air at the last month in all of your cases?
The reason why is because we want to be very dry at that time. When you put the glue, now you have to make sure that the entire area is very dry. You don't want even aqueous to come out, because the glue will not work. So that's the reason why. Nowadays we're not putting air. These are some old videos, but because if you put the air, make sure that it's not wet. If it's wet, the glue will not work. So you have to put the glue and wait for about 30-40 seconds, and it will work wonderfully well. Over to Amar.
Thank you very much, Mohan and Sujata. It's a great course which you've been conducting for so many years. Those who are standing, they can come inside also. And so let's see now. Everybody knows about these techniques of implantation. I thought I'll show you something different here. Here you have a patient with microcornea. There's aphakia, that means there's a PC rupture, and there are sombering ring present. So that's a triad. Now, why am I showing you this is a case like this. Question comes, what lens do I implant? How do I fix it? And also, how do I remove these sombering rings? Now, remember one thing, implantation of a normal IOL in such eyes, in a microcornea, this is a small eye, it's like a fetus in a womb. The whole IOL will get crumpled up. So don't implant a normal IOL inside. We published in 2015 glued IOLs in eyes with microcornea. The reason is very simple. When we are doing a glued IOL, the haptics are outside. So if I take a 7mm white to white, I only need a 6mm optic, because my haptics are outside. In other words, my message is, in a microcornea eye, please either do a Yamane or do a glued IOL. Even the Canabra will not work, frankly, in such cases. Now, the second problem here is, how do I fix the fluid? This is the trocar AC maintainer. All of you if you are using an AC maintainer, the problem is you make a knife incision, then you tighten it, then it will be tight or loose. This is a trocar AC maintainers is going 0.5 millimeter from the limbus. But watch it, it's above the iris. Very simple. Available by Alcon, you can get them from, you can get 25 gauge, any gauge you want. We published this in the year 2016, these trocar AC maintainers, and they are like a valve. So all you need to do is fix them. The problem here is if you fix an AC maintainer, it can distort the cornea. Can I fix a pars plana? In a microcornea, I don't know where my pars plana is, to be honest. I can create a retinotomy, choroidal hemorrhage, or create some drastic complication. Now, once I got fluid in my eye, I'm making my 22 gauge sclerotomy 1 millimeter behind the limbus. Now, if you see Sommering ring, which was shown by D.W. Sommering, the problem with them is, if you leave them behind, what happens? The problem is the IOL can tilt. 2, they can drop down. 3, they can produce an inflammation. So there are various complications by leaving a Sommering ring behind, a case in which we had to remove it, which had dropped down. So now I've got a multiple factor here. We had published a technique of the scaffold, where we are putting an IOL for PC ruptures for the nucleus removal. Now we thought, can we combine the glued IOL and the scaffold? Now here you see a patient with a Sommering ring, microcornea. I told you, clearly we'll use either the Yamane or the glued. I prefer always the glued, to be honest to you. But the second point is, I'm fixing the glued IOL now behind the Sommering ring. Now once I've done that, the glued IOL works like a scaffold. In other words, ladies and gentlemen, I've combined the glued IOL we've combined with the IOL scaffold. Now those Sommering rings cannot fall down. And with the phaco probe, you can just emulsify these very easily. And we published this also in the year 2015. So now you got the gist of the story. Now look, I'm just going to now go in, implant the IOL. This is another case in which I was doing the same thing, but look, the mistake I'm doing here is I'm implanting the glued IOL anterior to the Sommering ring. Obviously it will not work. I have to go behind the Sommering ring. So remember, the IOL scaffold is always behind the Sommering ring. So here you see now I'm just catching the haptic. Once the first haptic is caught, my optic will go behind the Sommering ring. Now I do my handshake technique. So you transfer it from one hand to the other. This is the no assistant technique. Catch the tip of the haptic, externalize. So far, so good. Now I create the Chariot's pocket. Now in a microcornea, I'll have extra haptic. So all I need to do is cut the extra haptic with a scissor and tuck the haptics inside. Once my haptics are tucked, my lens is in place, I'll use iris hooks and dilate the pupil. Now break the additions from the Sommering ring and the vitreous with the vitrectomy probe. Bring the Sommering rings to the center. Now remember, I don't have any fear of the Sommering rings falling down because of the glued IOL inside the eye. All I do is remove them all one by one, and you'll see in this case of Sommering ring, the Sommering rings are removed. So what have I tried to show you basically is, we are doing glued IOL in microcornea. Plus, when you have a PC rupture with Sommering ring, use the glued IOL as a scaffold and remove them. Here you can see finally the fibrin glue being applied, and you can see in the microcornea, this was a patient with 8 millimeter white to white, post-operative day 2. And 1 week post-op, you can see the nystagmus also present. The patient improved to 636. So this is the basic take-home message where you can use the glued IOL or the Yamane technique. The IOL acts as a scaffold, and also emulsification of the Sommering ring happens. The basic problem here is these Sommering rings can fall down, and we have eliminated it all by using the scaffold technique. Only thing in this, first we are doing the glued IOL and using that as a scaffold, which makes the whole game a bit more easier in such cases, because there's no other way you can manage it. Saying that, I'll just show you another case. And this patient had come to us from Philippines. okay? And when I saw the patient, to be honest to you, I couldn't see anything. Now I'm wondering, what am I going to see in this patient? So here I'm taking off the epithelium, and I'm telling you, I still don't see anything. So I used an endometer, I still don't see anything. So now I fixed a trocar AC maintainer, and you can see faintly an IOL present there. But I'm not seeing very clearly, to be honest to you. So now, what I thought was I'll make my scleral tunnel incision. Now I made my scleral flaps. I made my sclerotomy 1 millimeter behind the limbus. Now, watch what I'm doing. I'm passing my endoilluminator inside the eye. Then only I could see the iris claw lens. And one is lying in the vitreous, the other portion is stuck to the iris. So now what I did was, we tried to lift the IOL up anteriorly. So I'm using one hand with a forceps and the other hand trying to dislodge the iris claw from the other portion where it's stuck to the iris. Then finally took the scleral incision, enlarged it a bit, and explanted the iris claw IOL. So here you can see I'm just showing this endometer being passed, catching it and pulling it out. Once that's done, my next step is to do the glued IOL. That's quite simple because I already have a large incision. All I need to do is pass it like a non-foldable IOL. I'm using an endometer from outside we are trying to use so that one haptic can be seen easily. Then I do the handshake technique, transfer the haptic from one hand to the other and catch. There you can see I'm catching it. It's difficult to see with all this cornea being so bad, but either way, it is still possible as you are seeing here because of the endoilluminator being used. Once both haptics are out, then my next problem is what? I have to repair this iris, remember that. So here you can see my second haptic caught, pulled out and externalized. Look at the amount of haptic externalized. That's very important. If you go too posterior, you will not have enough haptic externalized. So the moral is don't go very posterior. I go about 1 millimeter from the limbus. Once both haptics are out and tucked, my next step is to go for the single pass, 4th row pupiloplasty. So here is simple technique. You pass it from one end, clear cornea, through into the iris. From the other side, through a 26 or a 30 gauge needle, paracentesis. Now railroad the two, bring that loop out. Remember the number 4. Pass it 4 times and pull on either end to repair it. Now once that's done, you can see the mess which the iris happens because it starts cheese wiring in such bad cases. Now another problem here is the desmase and the endothelium is so fibrotic in that area there, I am just not able to continue. So what I thought was leave the 4th row for some time. Let me try to remove all this fibrotic membrane. Look how fibrotic the area has become. That's the desmase endothelium, all the fibrotic tissue attached to it. And the worst part is it's also attached to the iris. So you can see I have to remove it very carefully using the vitrectomy probe, breaking the adhesions from the membrane and the iris. Once that's done and I can start seeing better, then I will try to complete my 4th row pupiloplasty. So you can see now, I'm now completing that 4th row pupiloplasty which I left in the middle. And you can see once that is done, then you start seeing the iris coming back a little bit to shape. But there is a small problem. You can see so much traumatization of the iris there. I'm trying to do more and more of the 4th row pupiloplasty as much as I can. But remember, I have to accept the reality. I'll not be able to do too much. The issue is to see that Purkinje image. That has to be bang centered. So see the image P1 in the center. Now there was an iridiolysis on the top. So those of you who want to repair that, fix a trocar right opposite it. Take a double arm Proli needle. See the first arm going through the iris into the sclera. Now all you do is pull. And once you do that, that iridiolysis can be repaired. Now we do the PDEC technique, which is pre-desmase endothelial keratoplasty, because we feel this is a great technique as I can use only young donors. And to show the final clipping here in this picture, you'll see the graft attached there. This patient came from Philippines, so remember, he can't come back to me. So I had to finish all in one sitting. So let's see the final picture. This is pre-op, post-op, day 4, and post-op 2 weeks, the patient vision improved to 6/12. So what did we do? We did the iris claw lens explantation, we did the glued IOL, we did the photoreoplasty with the trocar acid iodialysis, and ended it with the pre-desmase endothelial keratoplasty. Thank you very much, ladies and gentlemen.
That was an incredible talk with lovely videos, Amar, as usual. I think what is important is Amar has shown that, and we have also had a huge experience since 2007, the versatility of glued IOL is something which is even in a cornea which is not very clear, as he rightly showed, we can go ahead and externalize the haptic as long as you follow the simple basic protocols. So we'll have some time at the end for discussion, and over to our young superstar, Nivian Madhivanan from Chennai, and he's going to talk to us on, are you ready, Nivian?
Yes, sir.
Okay. And on iris claw lens, and also a CMT flex lens, which he has invented. It's a really fantastic lens, especially when you don't have any posterior capsule, and you can implant that as well.
Thank you, sir. So, respected teachers, senior ophthalmologist, my dear friends. So, I'm Dr. Nivian, and I'm going to talk on 2 halves. The first half will be on, can we have the video? Oh.
There only. It's not coming?
So, the first half will be on the retropupillary iris claw lenses, and the second half will be on the CMT flex IOL.
Okay.
So, as you all know, it's a challenge for any of these secondary IOL fixation techniques, and
Amazing.
1 second, sir. So your screen, there are 2 screens, sir. I'm not able to see that screen. The screen is not showing.
Or you can set it right, and by the time Manoj can go. Huh? Even let's not waste time. We don't have much time.
Or just let it run.
Manoj, go this side.
Let's say that. Just a video, sir. Yeah, I'm sorry for this thing. Yeah, so the first half will be on the retropupillary iris claw lens. So as you all know, it was Verse to first describe this. So he was actually inspired by the claw lobsters that made him design this. So it's the IOL as such is a relatively simple design. It's an one piece, one material, and the whole mechanism is based on how the iris tissue gets.
1 minute, Nivian. Can you reset the timing? Yeah, thank you.
Yeah, so the whole mechanism is based on how the iris tissue gets enclaved within the lenses. So I'll just show you the surgical video. So as you can see here, there are two things that are important here. One is to know where you're going to clip the iris and where the tissue is going to get stuck. And the second thing, the use of the right forceps. You need a slightly broader forceps because if you use a normal forceps, sometimes it slips and you don't get that good grip. This is called the Shepherd's forceps. And also sometimes you have to check these lenses. For most of the time, sometimes it can be fused and then you go inside and then you keep pressing and you cause more damage to the iris. So these are just some simple tips before you start off with the procedure. So basically, this is an old aphakic patient where we had planned for a retropupillary iris claw lens. As you all know, since it's a rigid lens, so you'll have to do a sclerocorneal tunnel. For any secondary IOL, always stain. I think my mentor, Dr. Mohan, already emphasized on this for two reasons. One, once you stain and wash, you can see the vitreous clearly, even though at the start of the case, it didn't look as if there was much vitreous. The second, that little amount of the vitreous that goes inside also helps in preventing post-op CME. So it has a double advantage. So do a good vitrectomy, because for any secondary IOL, a good vitrectomy is the key, because later on you don't want vitreous in the section, which can increase the rate of endophthalmitis or cause any peaking of the pupil. So as long as the claw lens, again, just the tricks. I do a method in which I take my left hand inside first to the area where I want to clip. This is very, very crucial, the mid-periphery of the iris. Because if you go too anterior, that is when you get these cat-eye shaped pupils. And sometimes when you go too posterior, you can damage the root and can cause bleeding. So I always take my second instrument first to the place where I want to clip, and then I take the lens inside. And then clip it. So the later on videos, I'll slow it down slightly and show you. Here again, you can see my second hand is already waiting where to the place I want to clip. Then the lens goes inside and then the clip. So in the second case, then the positioning, always 0-180 degree is ideal. So here the second trick is you push your right hand up and push down your left hand. So when this happens simultaneously, it is also easier to clip these lenses rather than going and searching, because intentionally what happens, the hand where we're holding the lens keeps going down and you keep pressing. So you're not actually going to get that iris tissue getting enclaved. So whichever hand is holding the lens, go underneath and lift it up. So you see that small bulge that comes on the iris, and then the second instrument pushes it down slowly here, and then you see a small dimple. That dimple is a sign that some amount of iris tissue is enclaved. It doesn't have to be full thickness into that. It can just be a small dimple that you can see here. You can do this in other combined cases also. So the basic thing is for the iris claw lenses, one, you need a good round pupil. That is the only indication, I think, where there is a bad pupil or where there's an iridodialysis, this lens cannot be done. This particular case, it had glaucoma also, so the glaucoma surgeon did superiorly at the trab, and then we did the temporal. Why I wanted to show in these cases, in these sometimes old aphakias, the pupil is very rigid, and sometimes we get this iris starring when we do these lenses. So the third trick here again is good amount of viscoelastic, hold the lenses. The second instrument can be used to guide the iris. So you don't have to, I've seen sometimes people forcefully taking the second haptic down under the iris, so that time also it can cause damage to the iris and bleeding. So use the second instrument, stretch the iris, take the lens down gently, and then clip it. So again to the mid-periphery. So we routinely do not do PA in these cases, because we have done a large case series which was published in IGO, which compared and said that is not the only sole reason for the claw lenses causing glaucoma. But this particular case, because it was a known glaucoma patient, we did the PI. Yes, complications are there in every secondary IOL procedure. You get irregular pupil, iris bleeding, iris tear, breaking of the haptics when too forcefully done, or non-clipping. So this was one of our publication. And the second publication or the contraindication is you get something called the pseudophacodonosis. So I was fortunate enough to work with Dr. Amar sir, and then we compared between glued IOL and these claw lenses, and these patients having this complaint of pseudophacodonosis because it is attached to the iris. So these are some of the disadvantages, but you get round pupils and good dilatation so that the fundus examination can be seen even in these cases. Moving on to the second part, the CMT Flex IOL, so no financial interest. So this basically is a single piece hydrophilic lens which has got specialized T-shaped haptics on both sides. So when these T-shaped haptics are brought out of the sclerostomy, opens up and gets fixing there. So that's the basic principle on how these CMT Flex lenses work. So this was one of the first designed IOL for aphakic management. So again, we'll go through the basic principles for any secondary IOL. So here we have a case of aphakia. So the first thing is the 0-180 degree marking, so which is very crucial for any of these secondary IOL procedures. So here we are just using the Ashwin's glued IOL marker to make the 0-180 degree mark. And on both sides, a 2 by 2.5 millimeter partial thickness scleral flap is fashioned using a crescent blade. So now once that is done, measuring 1.5 millimeters away from the limbus, a 23 gauge sclerostomy is done. So this sclerostomy either you can do with a needle or you can use your 23 gauge MVR blade also. So you can use the same sclerostomy to do the vitrectomy. So once the vitrectomy and the cortex is removed, so these are the specially designed T-flex forceps. And this other advantage of this lens is it can be done through a clear corneal incision. It's a foldable lens. So as you can see, once you inject the T-shaped haptic coming out first, so ideally if you can grab it, what is called as the head-on position like this is the ideal position, because when it comes out through the sclerostomy, it bends forward and it's easier for the lens to come out. But you can hold the neck or the arms off the lens also. The second point is, at this point, just inject the remaining of the lens. Don't pull it out because it's a single piece lens, so it can actually detach. So just hold it and wait for it. Inject the remaining of the lens. Leave the trailing haptic either in the wound or over the iris, so wherever you're comfortable, and then slowly pull out. At the sclerostomy side, you're going to have a tug because that is where it's going to come out. So don't be in a hurry to pull it out. Just give it a tug. You'll see the T opening up and stays there. So just a small animation clip. It can be loaded and done in any of the regular IOL cartridges. Just the routine 2.8 millimeter incisions in the clear cornea. So there's no special cartridge for this. Just make sure that the T haptic comes out first, so when you load it by yourself, so that way it makes it easier to hold it. So once you hold it, inject the remaining of the lens and then you bring it out. And for the second thing, you use the handshake technique, as you can grab one arm of this and using the second Pranav T-flex forceps. So we also have the Nishi grasping forceps. Basically, they have serrations because it's a hydrophilic material. You don't want any sharp instruments holding it and biting into the lens. So here, exchanging the other hand, and being a hydrophilic material, it is very tissue forgiving and it is flexible. So you don't have to worry about any tissue damage inside. So once you have a good hold, and then now you bring out the other side. So once that is done, because of the 0-180 degree marking, then you don't have to do anything else. The lens sits in place. The third thing that we have done is there is a small angulation between the optic and the haptic. So basically that prevents the iris from rubbing it and having pigment dispersion. So you have good dilatation post-operatively. You can glue the flaps and the conjunctiva, or you can suture the conjunctiva, or you can even cauterize it. So I think you can do any of the two, because once that is done, because of the thicker haptics, there is no leakage here. So this is the day one post-operative pictures, a few corneal folds. As you can see, nice round pupils. And these are some of the studies that we did with UBM to show the positioning of the lens and also long-term effects. We almost have a 5-year follow-up now. So how the sclera behaves where the T junction is outside. So this can be combined with other challenging cases also that I'm going to show you now. So this was another case post-trauma. This you can see a cystic bleb also and superior iridodialysis. So here again the other advantage is you can measure any 0-180 degrees. So you can even go vertically or horizontal. So basically here again you can see 1.5 millimeters away from the limbus. And you can avoid other areas. So this you can see is the lens. I usually load my lens myself, so that makes sure that I get the T haptics out first. And there's also a dialing hole, as you can see on the top right. So that also gives you the clue that that is how the angulation is there, so it doesn't flip the other side. Some of them use that dialing hole also to hold it with the dialer when they do the handshake technique, isn't it? So there are other reasons why you can use the dialer. So here again you can see, even though it looks decentered, it's because of the superior iridodialysis. I think SFT is a brilliant and very easy technique for any of us to do. So we did the single pass 4th row pupilloplasty here to get the pupils back into anatomical position. So as far as anterior segments are concerned, yes, the main secret for any secondary IOL is the hypotony. So make sure your globe is not hypotonous when you do any of these secondary IOL procedures. So I would suggest definitely use a AC maintainer or a trocar AC maintainer. Because we are surgeons, I prefer using the trocar because that is easier to do actually, because now all of you are trained with intravitreal, so it is not very difficult. But this particular case, because the eyeball was formed, we didn't use any of the two. But again, there will be a challenge if it starts shallowing. So I would suggest not to do unless you use a AC maintainer or a trocar maintainer. The message is it can be done even by anterior segment surgeons. So this was one of the modifications of the technique where we just do a partial groove. I think the other people who have done modifications like using the Hoffman's pocket also, they have done it so that the haptics get buried under the Hoffman's pocket. Here again exchanging the other hand. So this was an old SICS patient with asteroid hyalosis who was referred to us for aphakic management. So here again, as of now, there's only one standard IOL design, so hypermetropes should not be a problem. Sometimes myopes which have high axial length, you either have to come at least slightly closer to the limbus. And for any secondary IOLs, just make sure at the end of the surgery, you just check as long as there is no vitreous in the antechamber. Even though you have done a good vitrectomy, this is another thing you can always do. Just put in some tricot and then just check as long as there is no vitreous in the antechamber. And again, we had glued the grooves and the flaps. Yes, there can be breakage, or sometimes when you use these sharper VR instruments, it can bite into the material. And late dislocations we have not had, but certain cases of iritis, but it is as comparable to any of the secondary IOL procedures. So it was a long journey of 7 years from the drawing board to what it is, and people have started using it, and we have a lot of publications. So once again, I'd like to thank Dr. Mohan, Rajan and Sujata ma'am for this wonderful opportunity, and Dr. Amar sir for always being inspiring. And if you've seen most of my videos, I think every time when he innovates something, I try and use it, and the next year he comes up with another innovation. So thank you, sir.
Thank you, Nivian, for the wonderful innovation, and it's going to be, I'm sure, it's a game changer for all of us. Before Manoj goes on to the dropped IOLs, I want a quick poll. How many of you do iris claw lenses? Yeah, it's a very simple, easy technique. How many of you do glued IOLs? How many of you do sutured scleral fixation? Quite a good number. How many of you do AC IOLs? How many of you leave them FA kick? That's also a good option. That's why I wanted to know. Because if you have any problem, if you're not able to decide where your capsule is, sometimes the pupil becomes small, put iris hooks, okay, you know exactly. Sometimes you put a lens on the capsule, thinking it's the sulcus, next day it will be on the retina. So if you have any problem because the pupil becomes small, your mind is also agitated, you can leave the patient aphakic, and after a couple of weeks you can take them, assess them on the slit lamp. By the time there will be a fibrosis of the capsule as well, and you can put a lens easily in the sulcus. So over to Dr. Manoj Khatri. He's a senior PR surgeon of Rajan Eye Care, and he's going to talk to us on dropped IOLs, which is again very, very important for us.
Thank you so very much, sir.
Mic on button.
And good afternoon, ladies and gentlemen, once again. Many thanks, AIOC, for giving us this wonderful opportunity time and time again to conduct this instruction course. I think it's almost, we are in 12th year now. So before I begin, let's have a show of hand. How many of us would have dropped intraocular lenses? Yeah, there are quite a few, almost half of all. So let's talk about the principles of management. No financial interest in my talk. But before we begin, the most important thing in this kind of management is a good bimanual anterior vitrectomy. Mind you, this includes toileting of the wound, separating the irrigation and the cutter port. This is very, very important, and always staying in the center of the pupil. You don't have to go and chase the vitreous. Never chase the vitreous. The vitreous will chase you. Okay? It's always reverse. So stay in the pupillary margin, do a good anterior vitrectomy job, thorough toileting of the wound, and if you're not able to implant the intraocular lens, don't drop it inside the vitreous cavity, just leave it at this stage. But there are instances like this surgeon, when he was implanting, he didn't implant only one intraocular lens, he implanted almost 3 intraocular lenses into the eye. So these kind of instances should be avoided. Be aware of the complications. Complications can happen in best of the best hands, but you should know how to manage it. So these kind of disastrous things should be avoided. Sometimes we have done a good phacoemulsification, but a small carelessness on our part when injecting the intraocular lens can tilt the outcome in the other way around. As in this case has happened, the surgeon was not careful and implanted the intraocular lens into the vitreous cavity. So small, carelessness can lead to a big way and should be avoided. Always be careful whenever you have a problem. These are a couple of our residents who are operating. Whenever you have a problem, call for help and immediately don't try to mess it up even further. So always be careful. So what we have devised over a period of time, this was a thought given by Abhay Vasavada sir about 9 to 10 years back. Can we do something different in the steps of anterior vitrectomy? So here we go. What we try to invent here is, or what we try to do, is try to do a pars plana vitrectomy approach rather than doing a limbal approach. It's fairly easy, can be done by any of us who are there in this hall. The only thing is that your direction of instruments goes towards the optic nerve rather than going towards the pupillary margin. And you just have to do a 2-port incisions here. So here in this video, we will see that the infusion cannulas here, this is a 25 gauge Alcon-based trocar system, but it can be used with, you can use any of the systems which are available. Do a straight entry, it don't have to be an angled entry. And this is a case of a old case of IOL dislocation, but can be done as a primary procedure as well. So what point I want to drive here is, once you have an infusion in place, it can be as showed by Amar Agrawal sir from the from the limbal junction as an AC maintainer, or from the pars plana region. It gives you much more controlled environment. So this is the point what we want to draw here. Once you get a much more controlled environment, the rest of your maneuvers become very easy. The rest of the steps of vitrectomy remains the same. You need to be only in the pupillary center. You don't have to go and chase the vitreous. Use judiciously intraocular intravitreal transdermal acetonide as much as you want, a diluted one, and then just stay in the pupillary center and do the rest of the steps. Here are a couple of instances where we had challenging intraocular lenses removal. One instance is hydrophilic IOLs. Hydrophilic IOLs are very tricky to remove because you don't get a good grasp of it. This patient had a drop of intraocular hydrophilic lens with a capsular bag. And once we have completed a vitrectomy, the most important step here is a good posterior vitreous detachment. Once you have done this with suction-assisted technique or even a forceps grasp, you can remove these intraocular lenses quite easily. But you have to be little careful in grasping or getting the first grip of the IOL. If you're not careful, you can cause a macular break or a macular hemorrhage. So as what you see here is a good posterior vitreous detachment with a thorough vitrectomy done for this patient, and then only we touch these intraocular lenses from the surface of the retina and try to remove it off. The rest of the maneuver becomes quite easy. These lenses come out from the limbal section very easily because they are easily malleable. So what I'm trying to do here is getting a good view, a crisp view, and then only grasp these IOLs from the surface of the retina. Once you get a good grasp, removal becomes very, very easy. Now, there are instances where a rigid intraocular lenses, they pose a different challenge. This was one of the challenging cases where a rigid intraocular lens was lying flat on the, lying perpendicular to the surface of the retina. So catching these IOLs are becoming, it's little trickier because once the intraocular lens falls on the surface of retina, the haptic itself can cause a further damage to the retina in form of bleeding, tear, and so on. So the important point here is don't free the intraocular lens immediately from the vitreous. Do the vitrectomy in the other quadrants and then come to the intraocular lens in the last. And after freeing the vitreous from the intraocular lens, then only grasp it and remove it. So this was one of the challenges. One of our friend was very overzealous. Rather than only staining the anterior capsule, stain the entire vitreous along with it, and these kind of things should be avoided. As you can see here, the view is very challenging, and when you don't have a good view, even removing this intraocular lenses become very, very tricky. So these kind of maneuvers should be avoided. In spite of repeated washing of the vitreous from the saline, still the glow of the trypan blue is still there. So all these maneuvers, one should avoid it. Getting other challenges in form of corneal edema, associated inflammation, and so on, where your view becomes easy. And also if the patient has associated retinal problems, like this patient had a proliferative diabetic retinopathy, along with vitreous hemorrhage and a tractional retinal detachment, and a dropped intraocular lens. Though we have managed it quite successfully, but these are the challenging situations we can encounter. Induction of the posterior vitreous detachment is the key, whether the view is good or view is not good. So be patient. And don't try to mess up these cases further. Refer to your VR colleague. That's a point which I want to drive. In pediatric cases, we have to be very careful. As you can see here, the surgeon has done a beautiful PCCC, but still not very careful or confident while injecting the intraocular lens, and the intraocular lens has been injected into the vitreous cavity. This child was under general anesthesia, and we were called immediately, and we rescued the intraocular lens from the vitreous cavity, did a vitrectomy, and then implanted the same intraocular lens into the sulcus with optic capture. So sometimes you have to be little vigilant and careful. This was one of the rare cases we published as well. This was a capsular bag with intraocular lens along with the Retisert implant, which we don't implant nowadays, gone inside into the vitreous cavity. The challenge here was not removing the sommering ring, the capsular bag, and the intraocular lens. The main challenge here was to remove this retisser implant, which was slipping on and off from the retinal surface. But with careful maneuvers and following the basic principles, and with a good suction, we were able to improve the retisser implant as well. Couple of challenging situations as shown by Dr. Sujata, glued IOL with nucleus drop. In this patient, when doing the phacoemulsification, with a grade 2 cataract itself, the patient had a nucleus drop. So what we do it differently here is, we first finished the glued IOL. Very beautiful technique invented by Amar sir. So once you have done a good glued IOL here, the rest of the maneuvers become quite easy. You don't have to bother about the rest of the maneuvers because the view becomes very hazy and view becomes very good, and removal of the nucleus from the vitreous cavity is also quite simple. In the interest of time, I will run through my videos. So important point is managing complications should be the forefront for any surgeon who wants to learn surgery and meticulously, and no dias can get better with the people who are sitting here and who have guided us on the careful assessment and planning of each and every case. Avoid overzealous maneuvers, understanding the principles of management involved, and it's always a teamwork. These are my acknowledgements. Before I conclude, we request all of you to extend your wholehearted support to none other than our Dr. Mohan Rajan sir here. He is a leader, team builder, and visionary par excellence for Vice President 2025 AIOS. And we also extend our warm welcome for all of you to come and be a part of Tamil Nadu Annual Conference, which will be held on 16, 17, 18th of August in Chennai this year. Thank you so very much for a patient hearing.
Thank you, Manoj. You covered a very important topic. Since running short of time, I think I will go through this presentation very fast. Can you just have that presentation, sir? Yeah. These are my, what is important is flax in complicated situations, white cataracts, hard brown. How many of you do flax? Femto laser assisted cataract surgery? No, okay. Posterior polar cataracts, subluxatory cataracts, fuchs endothelial dystrophy, NHNT, neither here nor there, cataracts are very good, shallow AC. So you all know that artificial intelligence is definitely catching up in a big way. These are the machines which are available. I'm using the catalyst. I don't have any financial interest. The simple thing is about the flax is that because of the cost, everybody is not doing. Otherwise, the versatility is something which is akin to compared to Sachin and Dhoni. Dhoni is good in all formats. Sachin is good only in one format. So these are all the flax merits of flax. But one of the most important things is safety, precision, accuracy, predictability, faster recovery, bladeless technology. So let us see some scenarios. The hard brown cataracts, how it is there. I do flax for these patients unless the patient cannot afford. But these are all the difficult problems which if we do a manual phaco, there's a possibility of doing excess phaco energy. You can get a corneal burn. And along with the corneal burn, you can have also this thing. The corneal edema and also cystoid macular edema and something like a TAS which is there on the surface of the IOL. So what we do is combine the technology with the technique, and I have the Mohan Rajan chopper. I don't have any financial interest. Again, it's gone. What's the problem? Why it's going on? So this chopper, what we are using is something which is, I'll just show you one regular manual phaco and how different it is. And this is a manual phaco wherein you can see here I'm doing a capsulorhexis with the trypan blue because I want to make sure the capsulorhexis is a little larger size. So you continue with the phaco, and this is a manual phaco with very hard brown cataract, supra hard cataracts. So again, in a flax, you can see this is a grade 3 cataract, grade 3 to 4 cataracts. I'm sorry, there's a problem in the What's the problem? Video. Okay, I'll probably stop here and we'll take some questions. Huh? Any questions from the audience?
Yeah, can I?
Yeah, please.
Yeah, actually, this question was for Dr. Sujata, but I think anyone can answer.
You can proceed with the question.
Yeah. So we saw that in two cases she presented, there was a pseudo exfoliation and there was a dislocated lens after 7 or 8 years. So in PXF cases, can we think that we can put a CTR or a capsular tension ring in the first place?
Amar sir, you would like to take this?
When we have a subluxed IOL,
No, before, even if it is not there in a PXF regular case.
yeah, I tell you frankly, these cases are all progressive conditions. I straight away do a gluteal. By putting the CTR, I've seen 10 years later, no, CTR will lie on the retina with the IOL itself. So if you have a traumatic case, yes, you can do a CTR because that's not a progressive condition. But Marfan's, all these type of conditions, pseudo exfoliation, these are progressive conditions. It's not going to be there for some time only. So my personal suggestion is, in such cases, after doing everything, fix the gluteal. You'll be always safe. These patients will be like that for life. One small trick, I'll come back. One small trick I won't tell you also, if you're doing a gluteal, if the eye is more than 11 millimeters, you want to come more anterior. Remember that, because I want more haptic externalized. You will hit the iris. So make a small iridectomy in the area of the scleral flaps, so that when you come anteriorly, you not hit the iris, you go through the iridectomy. Next question, you said something just now?
Yeah, even if there is no phacodonesis also, we can think of doing
If there is no phacodonesis, if it's a normal cataract, then you can do no need of doing anything. Put normal IOL inside.
Yeah, but the cases that were presented, I think.
Yeah, if there is phacodonesis, 100% go for a gluteal because they are progressive conditions. They will not remain like that. So if you put a CTR, what will happen is you might get away now. 6 months later, 1 year later, 2 years later, the patient will have some dislocation, definitely. And then again, you'll have to go back for surgery.
And removal of CTR is very tricky. Even from the ciliary body region, if the IOL bag complex decenters, removal of CTR is very, very tricky. It slips.
What's the next question?
If I'm allowed, can I ask?
Please ask 100 questions. Who's the next speaker here? Vasavada group, no? Don't worry. You can continue. Madam, don't worry.
Yeah. So in this iris, posterior fixated iris claw lenses, the difficulty which I face is, I think the first the first tucking is done properly, but when I'm doing the second tucking, in the second opposite tucking, then I have problem because the AC collapses.
That's why I said do gluteal, na? I will answer.
I don't know what I do, so tell us this if I do.
I think one thing is you have to use viscoelastics, but not too much. When you're doing the second haptic, no, I just use it between the iris and the lens. So we just need enough space for you to grab it and go underneath it.
But it's a big wound, so the minute you enter, it collapses. And
Yeah, so second take, what we have learned is the first haptic tuck should be from a non-dominant hand. So the first haptic tuck you do with a non-dominant hand. Okay, then the second haptic tuck you have more control. Normally the mistake what we do is we do for right hand first. If you are a right-handed person, then the left hand always struggles because you don't have a grip. The IOL sometimes slips. So do the left hand first, and then same with glued IOL also. Once you want to externalize the haptic, do the left hand first. It's little easier for you, because the second haptic removal is always taking out is always slightly challenging.
One small thing I'll just mention before we close up because of the Vasa.
Amar, you can talk. I'm just showing some videos because this is just to show you how the femtocataract works. You can see how the pre-chop is already there, the rexus is already there, and the very fact that the gas bubbles are coming from the posterior thing, it means that the cut has gone all the way down. So again, another patient can see here how easy it is for you when you do a catalyst because it makes the life easy. You can see the EPT is only normally 30 seconds in such cases, brown, black cataracts, and that is the advantage. Another big advantage is, quickly I will go through this, the black cataracts and also the cornea catheter. It's a very useful technique as well because you use less phaco energy. And more importantly, in subluxated cataracts, I'm going to show you this thing wherein you can see here how the subluxated cataracts is, and very mature white cataracts. How many of you have had this Argentina flag sign problem? Many of us have had. So this is I think, absolute technique, foolproof technique for femtocataract. You can see here how the femtocataract works very well without any Argentina flag sign. Of course, other areas like the posterior polar cataract and the softer cataracts also, patients who are coming with 6/9, 6/6 vision also use, because I want to make sure that I am on the safe side. I tell the patients that safety is more important, and when I do manual, I do 100%, I give 150% safety when you have the catalyst. So if we have access to catalyst, I think you should do that. The only problem hindering is the cost. I'm sorry, Amar, you can go ahead to the discussion. Sorry.
We should close, I think, now, because the Vasavada group is there, and I tell you what, they have knives also.
Give
They'll
one last
come
message.
to all of us with knives. Thank you very much, everyone. I'd like to thank Mohan Rajan, Sujata Mohan for this lovely course, and most important, all of you. Thank you very much. We can take it offline, any questions, but